Welcome everyone to Interoperability Roundtable. This is an open forum fostering conversations around healthcare interoperability. My name is Jake Tunney, Director of Payer Solutions at Leap Orbit. I'll be your MC today. We're joined today by co-host David Finney, co-founder of Leap Orbit, and our guest, Samantha Olds Frey, CEO of IAMHP. Thanks for joining, Samantha.
Thanks for having me, Jake.
Absolutely. Leap Orbit is the trusted innovation partner to many of the biggest market-leading health data networks, including CRISP, Manifest Medics, and Sync Health, as well as the policymakers who oversee them. We are currently working on improving accuracy and accessibility of provider data with our product Convergent, an automated provider data hub. Convergent also ensures plans are fully CMS compliant, the No Surprises Act, and CMS interoperability rule. Like I said, today we're joined by Samantha Olds Frey, and she's got a great story. I'm really excited to share that with everyone here today. And through her visionary leadership, IAMHP has been able to facilitate the statewide mandate of a standard provider roster for all Illinois MCOs. And truly the result has been groundbreaking, proving that aligning on standards not only reduces provider abrasion, but drastically improves accuracy. So today, we'll gain valuable insights into Samantha's multi-stakeholder approach and how she successfully led the effort to achieve statewide success. Learn from her firsthand experiences and the valuable lessons she acquired throughout the implementation process. Understand the pivotal role played by policy in driving this transformative initiative, and get a glimpse of Samantha's inspiring vision for the future and the potential it holds. And as always, we'll have an active Q&A, interactive session towards the end. But throughout this webinar, I'd encourage folks to use the Q&A functionality in Zoom to ask any poignant questions that might arise. So yeah, let's dig in. Samantha, thanks for hopping on. I can't wait to share this story of how you're able to do this in Illinois. And I think it's turning into a great model that a lot of other states are looking towards. So maybe we should just start first sharing a little bit about yourself and then how you found yourself implementing this program.
Yeah, so I'm Samantha Olds Frey. I'm the CEO of the Illinois Association of Medicaid Health Plans, known as IAMHP. We are a unique trade association that we don't necessarily see models of elsewhere in the country, in that we represent the full industry of Medicaid health plans, both local health plans, sort of homegrown health plans, but large health plans like our Blues and our Aetnas. However, we solely focus on the Medicaid program. So that has led to some success and an ability to sort of innovate and to partner and collaborate, because we leave some of that general sort of competition that you have on the commercial side at the door, because we are all regulated by the same contracts, by CMS, by our Medicaid state agency, HFS. And so it does bring about a wonderful environment for collaboration. And that's really brought us to this, one of the many things that we've standardized, the standardized roster. And we sort of got to this point through challenges. I think, as any good solution, probably comes from some hardship. And what we saw were a few things that happened at once that led to this innovation. So first and foremost, we were seeing some lawsuits around provider directories, specifically ADA information and accuracy, not from our health plans directly, but in the space. And so we knew we needed to improve ADA information and gathering. There was also the CMS mega reg, the first iteration of the mega reg at this point, that required certain things around provider directories that we needed to get a better handle on. And then the third piece was changes in Illinois state law around Medicaid provider directories that we also had to handle. Some things that happened in Illinois prior to the No Surprises Act in terms of accuracy and review of the directory. And so with that, we all in our space knew that every single Medicaid health plan had to change their roster, because the current structure of their roster wasn't meeting statutory or regulatory obligation. So everyone was going to need to change. And we decided, well, why don't we standardize rather than each of the plans changing in their own direction and continuing to have some of the challenges that we've experienced, which is essentially providers not adopting the model, not adopting the standard templates, and the plans not getting the information they need from providers, and then facing significant risk with regards to provider directory quality.
That's awesome, Samantha. And so can you sort of take us through, I guess from start to finish, what it was like to, once the initial idea to create this, came to fruition, what were the steps like and what were some of the hurdles you faced?
Oh, the steps were many. It was an iterative process. It is not for the faint of heart. I had several 6 to 8 hour meetings where we were just going through spreadsheet by spreadsheet, whiteboard by, it was. So what we did, we started internally. We all agreed we need a new roster. Let's do this together. We collected every plan's existing roster at the time, went through every field. How many plans are collecting this information, and at the time, I think we had 12 plans or so. So it was a lot just to sort of go through, and then we would bring it back and we would say, okay, this is what we're seeing. And you all, maybe you're collecting this, but you're collecting it ever so slightly differently. Like, does your phrasing really matter? Is there a reason you have it this way? And, sometimes it did, sometimes it didn't. And so we standardized. We told some plans yeah, you're gonna have to drop that. We can't get it in. We can't justify this. So we had to, push back on some of the plans. But we first created our internal roster that was just with the plans and added everything in that we had from existing, and then what we needed. The big stuff was ADA. None of the plans had the ADA information that we needed, which is, incredibly prescriptive, like the width of hallways and the height of exam tables. Nobody was collecting that before. It was just an attestation, are you ADA compliant or not? And so those were all additions. And then we did, general things like color coding. If you look at our roster, it has all these beautiful colors and it corresponds to the instructions and then to where you're supposed to enter the data. And then we did some things where we decided on data requirements, military time versus standard time. How do we want the dates entered, stuff like that. And we sort of first focused internally, and that took long enough. Getting 12 health plan CEOs to sign off on something is 12 health plan CEOs signing off on something. The next step is we took it to the Department of Healthcare and Family Services, our Medicaid agency, and the Hospital Association with a handful of hospitals. And we fought it out there too, walked through every field, why we wanted it, why we thought it was needed, and won some and lost some. In terms of what we thought we needed and what they thought was reasonable to ask for. We did create the roster with the focus of being on Medicaid, and I should have started with this. In Illinois, our Medicaid plans do not credential our providers. The state credentials the providers. And then they send over a file of some of the information, not all of the information, but some of the information that they gather through that credentialing process. So if you were to just look at our roster and see things that are essentially preferred but not required, you in another state might be scratching your head like, how in the world is this not required? It's most likely not required because we receive it from the impact file, which is the file we get from the state. So we created this roster with that in mind. So there are certain fields that you would absolutely expect that we don't need because we have another way to get them. However, you'll see a column in our instructions for other lines of business. And there, oftentimes, those fields are required. And the reason we have that is that some of our plans have actually decided this is our roster for all lines of business. For Medicaid, we need, A, B, and C. For commercial or Medicare, we need A, B, and C, and X, Y, and Z. And rather than having two rosters, we thought it was as much more straightforward to have a single roster. So we kept items on that the state or the hospitals didn't necessarily understand why we would need for Medicaid, but we made it to preferred or required for other lines of business. And then we also have required if applicable. So we went through all of it with the handful of hospitals, the hospital association, and the department. We went through definitions and instructions. Like, does this make sense to you? Like, we know what we mean as a health plan, but do you understand what we're saying as a provider? And I'm sure you're not surprised to find out that we were speaking different languages sometimes. And so had to clarify our instructions and make things really straightforward. We also put everything in the spreadsheet. So the roster's in a spreadsheet, but then the instructions are there too. And our reasoning for that was one of the complaints we would get, one of many complaints, was that providers would complete what they thought was everything, only to get additional instructions or additional material requests. And it was driving them sort of batty. Like, we would go back to them and say, hey, you didn't do this. And they're like, no one told us to do this. And then we would do it at, it was a very iterative, tedious process for them. And so we put it all in one document, which doesn't always make it the most visually appealing, but it's all there. So like no provider rep could ever forget to send the instructions, but send the roster. Like, they are all, it's self-contained. So after that, we had some testing. We had a few hospitals agree to test with some of our plans. We made some tweaks after that testing. We finalized the version and put it out in the world. And then slowly found adoption from the provider community. The plans all accepted it, but not all providers used it. We had a public policy, a bill that required that all plans accept it about a year after we were already accepting it. And then a little bit later, we actually had legislation that required all Medicaid plan providers to use the roster. And that's where we saw some real change and some real improvement. And we had already seen situations where providers who were using the roster had improved claims processing, direct relistings, but the providers who weren't using it had that continual challenge because we simply weren't getting what we needed. And we saw that with the adoption of the standardized roster, great improvement in data quality and provider loading.
Yeah, that's really impressive that you're able to. And this whole process, I mean, it's been a few years, correct?
Yes, it is an ongoing. I mean, we're talking about tweaks and changes, and I believe, are on version 3 of it, and have like very minor tweaks that we're like considering based off of our last tweaks. But like, it is an evolving process.
Yeah, clearly, and so is provider data though. So I can imagine, new fields will be continually added in the future. Different fields might come off the roster. So the fact that you're able to establish that, multi-stakeholder approach and that iterative feedback mechanism, I think speaks to the adoption and the success where you're able to get, everybody's input. Was that, if somebody were to implement this today, I think that's a critical step. That being said, are there any lessons learned from that process that would have made that communication a little easier?
We did it in person, which I would recommend. It was challenging, but it fostered collaborative communication, even if it was hard collaborative communication. I do think it might be worthwhile to, depending on various stakeholders, this was really driven in part by the plans within the hospitals. Going back, I would have included some of our atypical providers earlier on, and some of our physician practices. I mean, obviously here in Illinois, our hospital systems own a lot of physician practices, so they were bringing both lenses, but perhaps FQHCs or another group of providers they might have brought in just to get their take, we've had to tweak instructions and add clarity simply because we weren't focused on their provider type when we were developing the roster. And so there were some unique things about them that we needed to update. For example, atypical providers don't have NPIs because they're atypical. And so trying to figure out, like, we made NPIs required, and how do you do that if you don't have an NPI? And in Illinois, our encounters reject if an NPI is listed on an atypical claim. So it just made it sort of like messy, that it didn't need to be messy if we had like had that conversation earlier. So a
Right.
broader group of stakeholders, talk internally, like don't, I think this is general, but have something you're pretty comfortable with and for folks to react to before going to stakeholders. I would recommend going to various stakeholders with really different perspectives separately. Hospitals and atypical providers are going to have like a really different conversation. And at least here, hospitals would drown out the discussion for atypical providers. We would never hear what they had to say. So having those separate conversations, I think would be really key. And then, having a state partner was really helpful for us.
Samantha, the description of how this all played out reminds me of the old days of health information exchanges, when the hospitals and the plans sat down and said, hey, why don't you give us your encounter messages? And the hospital said, well, hey, health plan, what the heck are you going to do with those? And how, so there's an interesting interplay between building consensus of the stakeholders and the hammer of policymaking and legislative action. And I'm curious what your take is on states that might want to try to do this today, and might be looking to jump straight to the outcome or skip a few steps in the process. I think our lesson from HIEs is that if you're going to have those negotiations in the context of a bill that's dropped and in committee, it's got a totally different group of people weighing in and a different dynamic. So is the stakeholder engagement, is that the essential ingredient, do you think, to pulling this off?
I do. I can't imagine when I got it legislatively a requirement for providers, it wasn't much of a lift. I'm the CEO, but I do a lot I come from a policy background and I still lobby when I have to. And it wasn't a hard ask. And that was because by that point, other than certain very large systems, it had been adopted. Mm-hmm. And so it essentially looked like those few systems just like weren't playing by everybody else's rules. And so legislatively, I didn't have a fight on my hands. If I had tried that earlier, without my collaborative discussions, without that stakeholder buy-in, it would have been a very different discussion legislatively. And I think I would have a few more bruises. Or I don't know. I don't know that we would have the roster, to be perfectly honest. It just would have been a political fight. The other thing that I think is worth noting is that this helped the providers too. Like it improved our provider data, absolutely. But they had at the time 12 different rosters they were trying to fill out. Right. And 12 different processes, and they were screaming for standardization on like everything. And so this was something we could actually standardize. And so we came at it from that lens. Like, yes, this roster is large. It is larger than some of the ones that had previously existed. But first, all of these rosters are growing one way or another because they are collecting what they need. Second, we can have them grow in a standardized format, or you can have 12 much larger, cumbersome rosters. And so they viewed it as sort of in their best interest as well to figure out what could work for them.
It's interesting.
So we had another stick.
Yeah, it's interesting though that you said the biggest provider organizations came to the party last, because it's one of those discussions where hospital systems compete with each other over market share and providers and all of those things, and provider organizations typically have a prickly relationship with health plans at best. I don't know what the diplomatic way to say that is, but like part of it is convincing everybody, hey, go ahead and compete and be fractious in all your other ways. Like this is not a competitive advantage for anybody. There's no secret sauce in the way that hospital A builds their roster compared to hospital B, right? So if you can get everybody to put that aside, or at least most people, that's a big step.
And what we did that at the time, we didn't, we got some flack for it, but it worked out. We included some of those large systems on the front end and some of our large academic centers that helped us create and test the roster. So they were fine to adopt it. They were early adopters because they built it. We heard them. They told us they couldn't do this or that it was cumbersome. So only to require, make it so it was preferred, or, we really tried to listen to them. So for those providers, we got buy-in. So if you're doing that, be strategic about your partners. Who of your large systems is willing to work with you? We had some plans that had solid relationships. And so maybe that provider wasn't going through the working group that we had, but they would be talking to an individual plan about the process separately. So we deployed our relationship strategically as well at that front end.
Interesting. I have a question in a slightly different vein, which is Illinois is not unique in the state kind of imposing centralized credentialing on the managed Medicaid world. And you hear in a lot of states how that data has all of its own problems. And so you talk a little bit about sort of when this better roster data starts to land at the plan, like they're probably second order things that folks started talking about when they're saying, well, gosh, as this data gets better, what are we going to do with the state's data and how do we decide what to trust in certain situations?
We trust the roster.
Okay.
We always say one day the roster will be smaller because the impact, or there'll be more that's preferred for Medicaid or not required for Medicaid. I think I've been saying that for like 3 years now, maybe 4. First, for us in Illinois, there's plenty of information that providers enter into Impact, which is our centralized system. It's never sent to us for whatever reason, or it's sent and it can't be connected. Like, for example, groups can't, a provider can't be affiliated with their group through the file that we receive. So we still need that from the roster. But we also find that providers don't necessarily, because there's a lag here in Illinois about updating Impact. There's a lag between when they update it and when it's approved and in the system, sometimes up to a few months, that certain updates from Impact just they're too delayed, specialty hours, stuff like that. So we trust the roster. Our hope is one day the roster will be a little leaner, but we're not going to jeopardize our claims processing right, or our provider directories off of that, because there are I think you just have to be honest about the quality of data that you're receiving from other sources and live in reality and not what would be you're nice to have. And here it would be nice, but it's not our reality just yet.
So your mention of lagginess in the credentialing data makes me wonder, have you guys tinkered with frequency of roster submission? What is the calendar speeding up now that this process is humming?
It does. So plans vary based off if they just want to change file or a full roster. We recommend full rosters at least quarterly across the board. Some really recommend it monthly. Some are fine with change files. But we would have providers that would send in a roster every 6 months before the standardized roster. Because essentially what they told us they were doing is 1 month I'm working on 2 of your rosters, and then the next month I'm working on the other 2, and the next month I'm working on the other 2, and eventually I'll get back to you. So, which I understand. I mean, it's just a capacity issue. So we do see now not everybody by any stretch, but we see much more providers sending in a monthly roster, which is ideal, than we were before. And there are some tiny providers that don't have changes. Like, I mean, so we'll see those less often. But we are seeing a great improvement in terms of the timing of the data we get from the roster.
So your sort of recommendations as an initiative, or even your state policy doesn't stipulate like a faster, I mean, CMS has its own rules, right? And that crank is spinning faster and faster, but you guys didn't need to take your own position because the rules kind of dictate at least what the expectation is.
So how we did it was the effective date of when we have to pay you as a provider. So what we call our liability effective date is the latter of the date you're contracted, the date you're certified by Medicaid, and the date you're listed on an approved roster. So if you don't send in a roster, but you're contracted in Medicaid, technically, you're not effective and the plan doesn't have to pay your claims. Now, should we do that? I mean, we definitely work with our provider partners, but are we well within our right to say, you weren't listed on the roster, I don't have to pay this, I'm going to deny this? Absolutely are. So that's how we handled that. Which
that's a big stick.
Solution.
I mean, that's a hammer, even if you don't use it, right?
Yeah. And so we get people on those rosters now, that's for sure. And they are allowed to submit. This is key because I mentioned the lag earlier. They're allowed to submit somebody on the roster before there is that Medicaid approval, because the Medicaid approval goes back to date of submission within that impact system. So our recommendation is submit the roster the day you submit your impact application.
Makes sense.
And then we just pend it until we get that approval. We can't load them, but we can sort of say, yep, that's your line in the sand. Like we see that you're here.
We've got a bunch of great questions here. I want to make sure we get to them. Let's touch on, I know we already sort of spoke about a few aspects of the results, but what are the other, improvements that you've seen as a result of this initiative?
So claims processing is probably the biggest one, and significantly improvement, both just from timing and just fewer errors, fewer denials. One of our biggest denials, I think, across the board in the industry is providers not loaded or not eligible for that category of service or that, whatnot. So we've seen great improvement there. We loaded to the right fee schedule. So we had a lot of issues where the code that was being billed was on multiple fee schedules, and here in Illinois, the payment was driven by, well, what type of provider are you, and sort of what amount are we supposed to pay you? And if we didn't have you loaded correctly, we might have been paying you more or less than you were supposed to receive, which either way was an accounting nightmare. One obviously a little more painful than the other. So we've seen that great improvement. Significant decrease in provider abrasion, because if you figured it out for, I'll just use one of my health plans, Molina. You figured out the roster for Molina. You figured it out for Aetna, Blue Cross, County Care, Humana, Meridian, as well, right? Like, those are the plans now, but there used to be more. And so you didn't have to schedule like in-depth roster meetings with 12 plans at the time, now 6. You just needed to find the one you liked the most, or the one whose availability was there, and sort of work through it all and, get that in there. Provider directories, I can't stress enough, have improved, which is critical for us. I mean, that's what our members use. That's what our care coordinators use. If you're navigating the healthcare system and your provider directories aren't accurate, it's difficult. And so, and the flip side of that is, from the plan side, they are creating those based off of the data we get from providers. So if we're getting data 6 months late, and it's spotty, our provider directories are spotty and 6 months out of date, and we know it, and we're facing a huge liability risk from that. So I think having this process created, it allowed us to avoid exploring other sticks around provider data quality that could exist. So there's that. The other piece is just the back and forth, right? I mean, it was there was the roster, and then there were like 15 other things that plans needed to collect from providers, and so pulling it all into one just made the process a lot easier for the provider community. So that's what we've seen, which, I mean, that's a lot. I mean, provider directories and claims are pretty foundational to health plans.
Absolutely. Yeah, you made a really good point while we were talking about planning this webinar. I think you said something along the lines of having the single roster essentially increased the opportunity of fixing mistakes. Because if you have one mistake and you have 12 rosters, that mistake could be in 12 different places. But then if you have to fix it only in one place, it's a lot easier to go fix that.
Yeah.
I mean, it sounds simple, but I think it's a really important concept, because we've had this debate of, how do we fix provider data accuracy? I mean, there's plenty of people involved in looking at this, and our company is one of them in the industry. And truth be told, no one's necessarily found the silver bullet, but we're sort of on the interoperability side of things, hence the name of the webinar, et cetera. And our product Convergent, which we can talk about a little bit later, really has interoperability woven into its DNA. But the question is, do standards and adherence to standards actually improve accuracy? And I think this proves that it does. It's not, you wouldn't necessarily think, oh, just because the data is being submitted more seamlessly, it's somehow more accurate. But I think your case study kind of proves that that's a significant benefit of adherence to standards.
I would say so. I mean, part of it is there's just some parts of the roster that are manual. I mean, I wish they weren't, but like, you're pulling data from a lot of different places, and there's just a human that's going to touch this data at some point. And if you have to fill out a roster 12 times, the likelihood that somebody's going to have a typo in a phone number or an office hour, or, misspelling a street name, or, pick your just general human error that I think we've all made on a daily basis. Misspelled a last name, or an autocorrect gets in there, and you know what you mean, but Excel thought differently. It's just decreased significantly when you only have to do it once. Now there's risk, like you do it once and you have the phone number wrong. It's wrong for everybody. But when it's identified, you only have to fix it once. Whereas like you have to, like, most likely what was happening before is an error was identified by one health plan. The provider was fixing it with one health plan, figured they didn't make the mistake with everybody else, or had to go back and check and realize they didn't. And it was just far more clunky and cumbersome than it is now.
Well, Samantha, I think there's two sides to that. I mean, one is on the provider or the submission side, but when you've normalized each of those fields on the payer side, it's also easier to identify problems, right? Like if everybody agrees that the business phone number field means whatever you guys decided it means, then there's no question when you're looking at rosters across lots of provider organizations, maybe for the same doctor. Oh, well, this is in two different phone numbers because I can see in 11 of the 12 it matches, and in the 12th one it's not, right? Or in techie, like nerdy jargon, we call this semantic interoperability. And what that means is that everybody has agreed on what the meaning of each value is. So, specialty and address and phone number, all of these things are concepts that are totally subject to interpretation and can mean very different things depending on who you're asking or why you're asking or where the data comes from. So I think like that's probably one of the things that you really got out of the stakeholder engagement. Like, all right, when we say phone number in column C, this is exactly what we mean, and everybody knows it.
Yes. And oh my gosh, David, it's so true. And one thing I want to really stress that like it helped members too, Medicaid members, because in our roster or in our directories today, or previously we had specialties, we had, trainings and focus, and every plan sort of had their own list of like, these are the things you can pick. And then providers, sometimes it was just like free form and they would just say things. And so like, what did it mean to have experience serving housing insecure members versus homeless members versus, pick? And typically it meant the same thing, but even within the same directory for the same plan, providers were listed a little differently. And then across the plans, they were definitely listed differently. And so we standardized all of that. Like these are the specialties and these are your special trainings and your emphasis, and these are your exclusionary populations and the services you provide. And we all use the same terminology because in healthcare, there's definitely a way to mean the same thing and say it like 15 different ways with 3 different acronyms. And so we tried to get away from that to the best of our ability.
Okay. That's amazing. Let me jump in because we've got some good Q&A coming from the folks here that are online. Let's jump to those briefly. Then we'll talk more about your vision for the future. David, I'd like to get your opinion there as well. And then we'll open back up Q&A at the end. Victoria, we've got a bunch of your questions yet to go through. So before we do that, and Heidi Wilson, I see you've asked 2 questions here. I feel like we've addressed the first one a bit, but I'll run through both of them. If Stephanie, you'd like to hit on either of them in any order you prefer. But so Heidi's asking, I hear that improved claims processing is a value for providers. Are there other benefits that help to encourage providers to adopt? So that's question 1. Heidi's question 2, why do you think some of the providers didn't adopt this before the state legislation? 2 some slightly related questions, mainly on providers. Yeah.
Some providers play better in the sandbox than others. Is probably the best way to say it. I mean, there were just large systems, just a handful that just said, no, we're not going to do it. Not the majority by any stretch. By the time legislation came through that required providers to do it, I would say 90% of our providers were using the roster, like if not more. It was just there were certain very large, influential providers that knew we weren't going to kick them out of our network if they didn't use it because they had the market share. We needed them. And so they didn't want to do it.
Yep.
Yeah, I wish I could come up with like a better, more elegant, that was it. They didn't need to until we made them.
And so, yeah, we touched on the value for providers. I mean, obviously denials being a huge one if you're, getting paid more accurately. And just seems like transparency into why you're getting paid certain ways and having trust that your data is being shared the way that you sent it in. Everyone knows is the way that we should expect it to be sent in. That helps give clarity to providers knowing that their data is getting updated the way they've sent it through. So we've got denials, transparency, visibility into the directory. So members are seeing them on the sites knowing, they can go and visit these providers.
And it was also loaded quicker. That's the other piece I would add. Yeah. Once the quality improved, it was easier for us to load it into our system. There was less manipulation. When we weren't getting it, when the plan wouldn't get the roster on their format, they got it on the provider's format. They had to manipulate quite a bit. They were missing things. So we were able to load it quicker, which meant we were able to pay those claims faster too, and list those providers faster as well.
Well, and the faster you load it, I mean, provider data has a half-life or shelf life, however you want to think it.
Yeah.
It starts decaying the moment it leaves the fingertips of the provider or the mouth of the provider, right? So we're talking about turning the crank. Like the faster you can push it out to where it needs to go, the more likely it's going to be accurate, right?
That's exactly it.
Yeah, and I want to put a pin in that, David, because once we get back to the future vision, I think there's a really good point to be made there. But let's ask Victoria's question first, and then we'll circle back to that. So Victoria's asking, how do you see this roster effort impacted by Illinois moving to a state-based health insurance exchange marketplace?
So it's a very interesting question that I cannot answer. I am recused from all commercial insurance discussions. I only discuss Medicaid for two reasons. One of which I only that's my membership for Medicaid health plans. The second is that my husband is employed by the Department of Insurance and was the chief negotiator on the state-based exchange. So I do not touch state-based exchange stuff with a 10-foot pole. Because yeah. So
fair enough.
Yeah, I can't. So sorry, Victoria. I can send you to somebody else to have some thoughts, but I think by and large, right now we see it as mostly just Medicaid.
I have a theory about this, just to plug the dead space since you're
sorry
about it. Kind of going back to this conversation about semantic interoperability and everyone agreeing on what things mean. At least for the state-based exchange where we've done this kind of work, it's like you can kind of think about it as like the family tree, the lineage of this data. You've got the providers at the top, and then it's aggregated at the plans, and then the exchange is taking the rosters from the plans and aggregating it one more time to feed it into the consumer shopping experience. And what we've seen with the exchange that we've done work with is you have all those same issues, right? Like, well, Molina says that this is the list of specialties that are going to be in its roster. And United says, well, these are the list of specialties that we're going to give you. And somehow that has to be reconciled into a single list of specialties that a consumer can search, right? And so we had, I mean, not in probably the same way, but we had a lot of those same conversations. And I would venture to guess that in Illinois, whoever is going to do that work will find that there's better alignment in the categories of data and what each category means when they start to send data to the exchange.
Yeah. And what I can say is we have plans that use the standardized roster for all lines of business. Like it's their roster.
Yep.
And their data quality probably looks a little different than folks that try to use multiple rosters.
Absolutely. I think that's a great segue to talking about sort of the vision for the future. So what I'd like to do is bring that pin back that we put in earlier, David. So thinking about, and Samantha, I'd like your opinion on this as well. As that dial continues to get cranked, and we're ratcheting up the speed of this data, we've got a spreadsheet now. Where are we going, and what might that path look like?
So we've sort of talked about this amongst ourselves, and so we are looking at sort of more of and I am like the least technical person in the world. The fact that I was the one that created this or like had to lead this discussion is it feels laughable, but I did it. And so we are creating a system sort of where it's more uploaded and it's just more dynamic online, and then submission to the plan sort of in a more seamless fashion rather than sort of a clunky spreadsheet that has limitations. At one point, I think, David, we already sort of talked about this. We would love better data from the state, where we are getting things a little quicker and linked a little bit better so that we could slim down the roster. That would be ideal. Those are certain things that I see. I also see that I think we try to explain this to providers, although it's not always appreciated, is that as more requirements come down for plans, timeliness, new information, accuracy of the information, it sort of turns the dial up or the heat up for all of us. And so, I have a funny story where there was legislation that we needed to have office hours within our directories, which is it's a reasonable request for sure. And so we didn't feel we could oppose the legislation. There were lots of groups on the provider side and the advocacy side that supported it, so it ended up passing. So we went and we updated the roster to require office hours. The amount of providers who supported the bill and then screamed at me over asking them for their office hours was not zero. I don't know where I'm going to get their office hours if it's not from them. And so as we think about all of this and as different groups are pushing for things, I think it's important to remember we're all in this one ecosystem, and sort of, if it sounds like it's a plan thing, know that they're going to turn right back around and ask you for it. Or if they have to update, every so often, or they have to verify, one of the things that we had to do No Surprises Act is we have to verify if we don't get a claim within 6 months. We've had to do that for years. Well, if the provider doesn't get back to us, we terminate, we pull them off our directory and we, we remove them. And then they submit a claim and their claim denies. And then they get mad that we did that. And we're like, well, you didn't respond to us. We are required statutorily to remove you. We can add you back in, but you got to send that information. So I think, guess just remembering it, it's like all of us, it might sound like it's the plans, it's only the plans, and then we have to figure it out. But as we sort of work through the system where directories are high focus, understandably, I navigate the healthcare system as a patient too. I get it. It's annoying when the directory doesn't make any sense. But that it doesn't just impact one part of the system, I think is really critical. So improving how the process looks from the provider community, making it easier for them to send it, getting better data from the state, but some collaboration around these various changes and a real appreciation for what they mean is probably necessary, because in a year, providers are going to go, wait a second, what? And we're going to say, we told you. And maybe it won't be a year, maybe it'll be less or more, but it's a complex time.
It's funny because sometimes, like in the business for us, people say, oh, you're working on provider data. That's a solved or like that's an old problem. It's not, there's nothing new there. Like people aren't doing, it's spreadsheets flying around, right? And I think it's such an exciting time in this space, partly because the CMS, especially the regulators, are just really turning up the heat, and I think at least they appreciate why provider data is one of those ingredients that really drives a lot of the dysfunction that we have in our system. So I'm totally with you on that one.
It's foundational. Like I always say, if you don't know who your providers are and you don't know who your members are, like, how are you operating healthcare? And you're not, or it's messy and you're making mistakes. And so provider data is that first piece. Who are your providers? What are they doing? Where are they? What are their office hours? I mean, these are all really basic things. And I think to your point, it is a bunch of spreadsheets flying around, and that's part of the problem. We have it's solved because we kind of agreed that it was going to be clunky and then moved on. And the fact that one spreadsheet instead of 12 is innovative is probably a concern, or should be a concern. And that one spreadsheet instead of 12 was hard to get to.
You don't even have to finish the sentence. Just saying the first part of the sentence and letting it hang kind of makes the point.
Yeah.
Yeah, I mean, my sort of, the world that I see in the future is one where the provider organizations basically make all of this available to interested parties in real time. Like you can think of it as a publish and subscribe model, right? Like I'm a hospital system and I have a a place where interested parties can subscribe to changes in my payroll, right? Like all my employed docs. If somebody quits or gets fired, I can shoot off a notification. Hey, something new is here. And all the health plans that I'm contracted with can in an automated way pick up that change and propagate it into their systems. There are a lot of other things in healthcare that used to be spreadsheets or fax paper that have kind of moved in that direction, and it seems inevitable to me.
I love that. And I think one of the areas where we face a lot of challenges, especially with our secret shoppers, is around where doctors are practicing at multiple locations.
Yeah.
Right. And the schedules change or they change and nobody tells us, or, so the doctor's still in our network, but they're no longer at the Irving and Western location. They're at the Hermitage location or, whatever. I'm obviously using Chicago streets here because those are what I know. But we'll get dinged. Like, you listed a provider that's not at this location.
Right.
And it's like, but they're in our network, they're seeing patients, and we didn't know that they moved locations because their claim's still going through because it's billed the same way and, all of that. And so if we could get, and it's difficult for the provider to tell us, well, on Mondays now, they're at this location, but on Fridays, they're here. And I mean, like, I know doctors that practice that way.
But that
And
data
so
exists. It's there.
yes, that data exists. So
Available.
to like link into that scheduling and have that more real-time information, it makes it better for a provider, makes it easier for a member, Medicaid member, or any health patient, makes it easier for the provider because they're not like trying to track all of that in a spreadsheet. And then it significantly decreases the risk and liability to a health plan because you're improving accuracy.
Yeah, there are trade-offs. I mean, in the long run, they're all good, but I was thinking of the office hours discussion, right? And it has real implications for network adequacy. Like if you have a Dr. Finney and he practices at 5 different locations, and each location has office hours of 8 to 4, let's say. Well, I'm not practicing at 5 locations 8 hours a day, right? So what you really want to know is what's my schedule? It's not when are the lights on and the door is unlocked.
To that point, our office hours are Monday through, like, we list out what are Monday office hours, Tuesday office hours, Wednesday. And then we tell providers, whether or not they do it, we tell them, if you're practicing at multiple locations, you're supposed to enter multiple rows. So like Dr. Smith, she practices at 5 locations. For the practitioner, you are supposed to tell us on Monday, she's at location 1, on Tuesday, she's at location 2, and Wednesday, she's at location 3, etc. I don't know that we get that. Like, I really, that is the instruction. It's tough. And like, does her schedule change? Like,
right. It's a snapshot
probably.
of a moment in time, even if it's perfect
Yeah.
at the moment, right?
Yeah.
But if it adds up to 200 hours a week, then you've probably got a
I
problem.
mean, we've gotten it wrong. Yeah. Yeah.
We've got a couple more questions. Yeah. I've got a couple more questions here that Victoria submitted before the webinar. So I feel like we should spend the last few minutes on that. Before we do that, I think one of my plans, I was thinking about demoing the Convergent and how we're thinking about implementing sort of an automated version of your spreadsheet roster, turning it into like an app-based version, and how that will produce better, more timely feedback for providers, streamlined process for getting data across to payers. I think I'm going to hold off on that just based on the amount of time we have left. If anybody is interested in that, I can drop my link to schedule with me here, and I'll include that in the link in the show description after as well. I just don't want to rush that, and I'd rather spend more time, while we have you here, Samantha, speaking, just talking about some of the questions that were submitted. And if anyone has some other questions they'd like to add as well, Q&A is open. So this is kind of circling back, and I'm going to read the first 2 questions here because I think speak to sort of the same type of thing. But first is, we were just kind of mentioning this actually. What are there still challenges with, I mean, it's a really robust roster you've set up. I'm sure, different provider groups have capabilities, varying levels of capabilities with submitting this data. So what are there challenges that remain getting data from them, and what are the maybe top few? And then, how are we ensuring consistent population of fields? And I think our tool will help address that. But like, what is the sort of topography of this data as it comes in? I know I'm sure it's improved drastically, but where are the challenges remaining, and how consistent are these elements being submitted?
Yes. So number one challenge that we need to fix is effective date. So we added effective date, and we get two different effective dates. We get the effective date of the provider and the effective date of the change. We wanted effective date of the change. Provider sent in an effective date of the provider. And so we just need to add a column for, we got to just pick what, basically we need two effective date columns. So that's like number one. It's always inconsistent. Basically, we added the column to help us, and it's essentially been not helpful at all. Because we get sometimes terms like proactively, like term this person in a month, which makes sense. Like that's helpful actually. But if we don't know what their data is of the change, like it's not helpful. So effective date. This seems really simple. If you take a look at our roster online, it's 3 tabs. It's the provider tab, which is like the actual doctor or practitioner, like the individual human being. We have the group tab, which is your location if you're not a facility. And then we have a facility tab, which is the facility, like a hospital, ambulatory surgical center, or nursing home. We have, especially this happens with FQHCs all the time, they try to fill out the wrong tab. Like FQHC is 100% certain that they are a facility. They're not. In our mind, they're a group practice. And we have it like in 4 different places now in our instructions, like what they are and where to complete it, but they still sometimes fill out the wrong tab. And why that matters is like the type of data you need for a hospital looks really different than the type of data you need for like an FQHC, which like obviously FQHCs, they're wonderful. I love them. I work closely with them, but essentially they look a lot like a doctor's office. And so stuff like that. Atypical providers are tricky. We touched on that a little bit. Office hours, like we get them, but like, that scheduling and that level of detail, we don't have a way to like, other than secret shopping, which like we cannot call every single provider's office like every week. We don't have a great way to verify that right now. So we have to take the provider at their word. Other improvement we want is telehealth. So we have a field that you can add that you provide telehealth, but it's not like you can add a myriad of things in that same field. So we're thinking of adding a telehealth field to make it really clear, like, does this provider provide telehealth or not? Those are the big ones. We fixed some things around NPIs and stuff that made them mandatory, because we found that when they were just preferred, if they weren't included, we had billing issues for primary versus secondary. So we just made them mandatory because we were just seeing improvement there. Those are the big things we still see on sort of like a regular basis that I can think of quickly. Did I answer all parts of that question?
I think so. Yeah, I think it's probably difficult for you to know, if you have, say you have a required field, how well across the board all those fields are populated for each record that's submitted.
We know they're not always, and sometimes we're able to like figure it out or not. We're able to do okay. Others we just like they just get rejected. And so, and we do see some plans are nicer than others.
Yeah, and that's one of the cool things. I hate to keep plugging our product here, but giving direct feedback immediately prior to submission on some of this quality and the ability to adhere to your standards you've set up is a really useful aspect of our tool. But just giving that direct feedback immediately will help improve, how well folks adhere to these standards. And, a lot of the times I'm sure that all the intentions are there. But so just giving them a way to see those things happen. So, I know we've got a few more questions. Samantha, I want to be respectful of your time. It's 2:00 Eastern. So we're going to wrap up, but I just like to say, like, we've got a lot of folks that are sort of asking if, maybe we could facilitate a couple follow-up conversations directly with you at some point in the future. We've got a really great cast of folks who attended here and folks that are, I see moving the ball forward in their respective states. So if you'd be willing to do that, we'd really appreciate that.
Absolutely. Happy to help. This has been one of my babies for the past, I don't know, 6 years or so. So happy to help in any way I can. And if you want to know what I've named the colors and our color coding, I'm happy to assist with that as well.
There we go. Awesome. Well, thank you so much for your time. This was a really great conversation. David, thank you as well. And thanks for everyone who attended and all of your active participation. So hope everyone has a great Friday, and we'll see you at the next interoperability roundtable.
Thank
Thanks,
you so
everyone.
much
Have a
for
great
having
weekend.
me.
Bye.